Good Monday morning, everyone. We are so excited to have you all here with us today at Archer Review, and I do have Sam in the chats. So if y'all can hear and see me okay, give me a thumbs up there. And we're going to go ahead and get rolling on our anemia presentation today. And we also have our case study. So if you happen to see this advertised online, we had Anemia Annie and a little story about her, and today we're going to go through the conclusion of that story and talk a little bit more about the workup. So without further ado, we'll go ahead and get started. I will mention just briefly SurePass right here on your screen. We'll talk a little bit more about that as our webinar goes. But if you haven't had a chance to check that out, don't worry, we'll circle back around to it. All right, so let's go ahead and get started. Y'all have been really wanting to talk about labs here lately. And, one of the things starting as a nurse practitioner, even as a nurse, that I can really remember is just feeling really overwhelmed by some of those basic labs. And we hear them talk about the complete blood count or the CBC or, different things that we can find out by the CBC. And it can seem kind of overwhelming and confusing. So I'm hoping to kind of break that down for you today and let us take a look at it together so that you don't feel so overwhelmed when you're taking care of patients out there. All right, so let's talk about just a quick overview with the down and dirty of CBC. So for example, we'll talk about the interpretation here. So remember, it's just taken with a purple top tube, sample of blood, a pretty easy, quick test for the patient, easy to order, pretty cheap overall. And so it's a great tool for clinical practice, something that I order every single day that I'm in clinic. And this measures the components of the makeup of whole blood cells, such as white blood cells, red blood cells, and platelets. And this can be helpful in diagnosing things such as anemia, infections, even some cancers for red flags there. In addition, if it includes a differential, it will measure the different types of white blood cells such as neutrophils, basophils, and lymphocytes. And Sam, who is in our chats today, had a great tip for you guys. The AANP will give you normal ranges of labs, and probably, I know when I was in school, we got normal ranges of labs on our tests. However, ANCC will not. I took ANCC, and that is correct. They do not give you the lab value. So that's something that you will have to kind of know. But again, of course, if it's abnormal, they do usually make it really obvious, really way off, so that you can, differentiate the right way. They're not going to make it like 0.2 off. And because again, remember, some of these labs can kind of vary. They're all kind of a range. So they're going to make it way, way off. It's going to be a glaring red flag to you. So let's talk about white blood cells. That's going to be at the top of most of your CBC panels. These are going to be part of your immune system, and we can talk about some of the terminology surrounding white blood cells. A low white blood cell count is a condition referred to as neutropenia. I have it right here at the top for you. This can be a sign of something like immunosuppression. You want to check and see if your patient is getting frequent infections and what's going on with them there. And then you also have leukocytosis, which is where it's an elevated white blood cell count, and it might also point you towards signs and symptoms of infection or inflammation. So something that you all want to think about too is, what is a normal white blood cell count? You guys can put that in the chats so that you know exactly what we're talking about as we go along, and I will give that to you here just in a minute. If the white blood cell count is really high, like something up over 100,000, they're going to need a prompt workup for leukemia. And that's going to be something that is going to go to hematology very quickly. And just a couple things that I want you to know, because I have seen some test questions surrounding this. Acute lymphocytic leukemia is the most prevalent childhood leukemia. And also myeloid leukemias is the most common types of leukemia in adults of the acute kind. So both of these conditions often will start with flu-like symptoms. So again, something that, if your patient comes back and they've been sick for a while, something that you might want to consider drawing as a CBC. And then also just a reminder here that leukemia is a cancer of the blood and bone marrow, whereas lymphoma is a cancer that begins in the cells of the lymph system. And that's going to help differentiate between your pathophysiologies here. And absolutely, guys, y'all got it. It's about 6 to 10. It's going to be your white blood cell count numbers. Again, some of those labs kind of vary, but so I've seen them even as low as like 4 to 10. So somewhere in there is where you kind of want to be hanging out and going to be okay. All right, let's take a look at lymphomas. So again, just a reminder, that's that one that begins in the cells. The two major types of lymphoma that we have is Hodgkin's versus non-Hodgkin's. And a couple of clinical pearls really to keep in mind here is that Hodgkin's lymphoma is rare, but more easily treatable form of cancer. And non-Hodgkin's lymphoma is a little bit more common, but the lymphocytes are going to really rapidly multiply in this, and it's generally more aggressive. So unfortunately, it's kind of reversed with how we would want that to be, right? And Hodgkin's is going to be those cells are going to be really rapidly multiplying and dividing, and these can, become more aggressive. And, some of the treatment plans for this is really good. I've seen really good outcomes with some of this, and then sometimes it's not. So it just really depends on which type that they have, and what's going on with the patient and how fast we treat it. All right, let's talk about platelet counts. So some terminology here that we have for you that I want you to know, just like with the white blood cell counts, is platelets are the blood clotting agents issued to slow bleeding. And thrombocytopenia is going to refer to something called a low platelet count. It's going to be thrombocytopenia. And then the term thrombocythemia, and again, I have these up here for you, is going to be a term for excess platelets. Okay, so you have your two different types. And a central thrombocythemia is a type of myeloproliferative neoplasm, just something you want to know. It's where too many platelets are formed. And the term myeloproliferative neoplasm just is a fancy word for anything that could cause cell overgrowth. So those myeloproliferative neoplasms, there's a whole ton of them out there. And so again, this is just kind of a terminology slide. And then the other thing is aplastic anemia. That's going to refer to when the body stops making any blood cells due to bone marrow damage, right? And this can be seen in cancer patients. Think about what chemotherapy does. Think about what radiation does in the body. Other contributing factors to someone having like an aplastic anemia outside of cancers is something like a chemical exposure, some sort of bad infection, or a genetic condition. So again, this is pretty concerning when we see these types of either neoplasms or anemia here. This is something that these patients really need a quick and prompt workup for. It could have a poor prognosis if not. Again, common signs and symptoms of this is going to include frequent infections, rapid heart rate, easily bleeding, and fatigue. And so I've got that here because if their platelets are low, they're going to be easier to bleed. Okay, multiple myeloma. So it's a type of cancer of the blood plasma. And this one here, the patient will often have low platelets and red blood cell counts. And as a reminder here, red blood cells are another part of your CBC that's going to help you to remember that these are the ones that transport that oxygen and carbon dioxide to and from the lungs. And there is no cure for multiple myeloma, and it is considered a terminal condition. So again, something that we want to see, if we see that those platelets and red cells are low, again, prompt workup, send over to hematology so that these patients can get a treatment and, they can have a little bit better outcome or, whatever, but it is still considered a terminal condition. All right, so on that note, red blood cells, they're the ones that carry that oxygen to and from the lungs and the carbon dioxide. So I want you to be thinking and put it in the chats what you think could be some common causes of low red blood cells. So I want you to be thinking about that as we go through this slide, and I'll circle back around and let's see if you got it right, okay? You all know I love to do pop quizzes on here. So this is something that is important for you to know. So again, put in the chats for me, most common causes of low red blood cells, and we'll see how you did. All right, let's talk about anemia. So many types of anemia. We're going to try to go through and hit the highlights on this one today, but you will have to decipher this on the boards. They're going to give you some lab values, and you will have to give the best differential diagnosis, or what could it be, some of the treatments for first-line treatments for your anemias. So this is something that you're not only going to be tested for, this is also going to be something that you see in the real world all the time. So to make it easier to determine some typical anemias, I've tried to give you some mnemonics here at the bottom that we're going to go through. So don't fret, we're going to go through this together. Now that we've gotten through some of this terminology, I do have just a couple more words for you to look over and to write down before we get started. So we'll start all the way over here on the left portion of the slide here. Chromic and cytic, okay? Chromic just refers to the color of the cells. So if I say the word hypochromic, you know that it's a pale color cell, okay? You know that cytic also refers to volume. So if I say something like normocytic, that means it's normal in shape or size or volume of the cell. And that's going to become really important here in a minute. So just pay attention to your terminology here. Chromic and cytic, they're just descriptor words that we're going to be using to help us determine the type of anemia we're dealing with, okay? So when we refer to a red blood cell as hypo or hyperchromic, we're going to talk about the color, if it's too pale, too rich, like I just mentioned. If we refer to a red blood cell as being micro or macrocytic, so I said normal a minute ago, right? But micro or macrocytic either means it's too big or it's too small. And we don't want our red blood cells to be various sizes and shapes. They'll have a little bit of differentiation there, and you can see that on the RDW, but you definitely want to make sure that they're kind of all more uniform. You don't want real big ones and real small ones. That could cause some sort of an issue. So you can determine that by your RDW. When trying to decipher the type of anemia, you may attempt to diagnose by looking at the lab value labeled MCV or mean corpuscular volume, okay? And that is really going to be your MVP here. And we're going to get to that just in a second, so don't stress. And it would be prudent to memorize this one, okay? So MCV is mean corpuscular volume. It's part of your complete blood cell count down there, usually somewhere between hemoglobin and hematocrit and the platelets, or it's going to kind of just be mixed in there, okay? And this normal level for this is about 80 to 100. You'll see a little bit variation, but again, remember, even if you're taking the ANCC, it's going to be way off on your test questions, okay? It's going to be, 140 or 72, it's going to be way off. And if it is lower than 80, you need to consider a microcytic anemia cause. So thinking about what could be a microcytic anemias, I've got them listed right here for you. Iron deficiency anemia, by far the most common type of anemia, also the most common microcytic cause, okay? And then also thalassemias, they're in there too. And then lead toxicity or intoxication, that's also going to be a cause for microcytic anemia. So I want you to think about tilling your garden outside, right? And these patients here, if you remember TIL, thalassemias, iron deficiency, and lead, you're going to be okay. So just to recap this slide, because this is really the meat and potatoes, you got to understand this slide before we can go on. Cytic and chromic, know those two. Lab value of MCV, you want to know that one is 80 to 100. That's the one that's going to help determine if it's a micro or a macrocytic anemia. Okay, so big cells we're dealing with or small cells we're dealing with. And then the most common types of microcytic anemias, aka MCV is less than 80, it's going to be iron deficiency by far, thalassemia, or lead, okay? And the other thing is I asked you at the beginning here, what can be some of the most common causes of low red blood cells? High red blood cells. And we talked about that. And for high, it's going to be things like smoking or sleep apnea. So anything that causes decreased oxygenation, those high altitudes. So that's something that can cause that increased red blood cell, like I talked about at the beginning. All right, so let's talk about iron deficiency anemia just a little bit more. So you're going to see your mean corpuscular volume less than 80, most likely, or around 80 sometimes. These patients are going to be a little bit pale. They might be fatigued. They might be short of breath. They might have brittle fingernails. And then pica. That's another one. Now, do you guys remember on that previous slide, I talked to y'all about tilling your garden? And I want you to remember that, because who can tell me in the chat what pica is? And there was a little hint, we till the soil or dirt, right? So do you guys remember what pica is? And what is that just a fancy word for? Do y'all remember? I'll give you just a minute to put that in the chats. Absolutely. Yes, that is that craving and or eating of non-food items like dirt or ice. So again, that's why I want you to remember to till your gardens. And one extra little tidbit when jumping back to lead, just for your knowledge, do you all know what a normal lead level is? Y'all can put that in the chats as well. Ideally, we want it to be 0, of course, but what could still be considered normal? Do y'all know? I'll be honest, I didn't know this one until I started studying for this lecture. It's 5, okay? So we want it less than 5, but ideally as close to 0 as possible, okay? In some states, this is a routine blood test in children due to like exposure to lead paint in older homes, things like that. So if you work with the pediatric population, just keep that in mind. It might be something that you have to order for that, okay? So back to our iron deficiency anemia slide. These are some of our most common signs and symptoms of iron deficiency anemia. All right, thalassemia. Remember our till our gardens. So the T stands for thalassemia, alpha and beta thalassemia. An overproduction of iron and red blood cells is what this one's going to be. Iron supplements are dangerous for these patients, so don't be giving them extra iron. And a lot of times to treat them, we're going to do therapeutic phlebotomies for treatment. And usually these patients are going to be also helping to be co-managed by hematology, and they're going to be the ones that does the therapeutic phlebotomies for these patients, okay? And how can we sort out, if we have a microcytic anemia, how can we sort out what we're dealing with? One of the things we can do is we can sort these out with a hemoglobinopathy panel, and that's going to help differentiate things like thalassemias, sickle cell anemias, different things that we might be dealing with if we have a microcytic anemia. And the two major types, like I said, are the alpha and beta for this. And this can be kind of common. And a lot of times these patients are going to be getting therapeutic phlebotomies for treatment. And if you know that for your thalassemia, you're most likely going to be okay for your boards, okay? Knowing that your iron supplements are dangerous as well, going to be important for you. So you can see 2 different types of microcytic anemia already, thalassemia and iron deficiency, and they're treated completely 2 different ways. So it's really important to come to a proper diagnosis, because the treatment for one is harmful for the other, right? So talking about labs to order, an MCV below 80 is going to be your lead level, like we talked about, a ferritin level, that's going to be your iron storage, right? Your total iron binding capacity, a reticulocyte count, and a hemoglobin electrophoresis, okay? So the next lab value that you're going to get, like we talked about, is lead, and then we're also going to get a ferritin. And then the reticulocytes are going to be your immature red blood cells. So if that's low and the red blood cells are being destroyed earlier than normal, could be. And then ferritin refers to the iron storage, like I just mentioned, and then iron binding capacity is going to be the one that helps to bind that iron up and transport it around the body. So I kind of call it hugs for iron. And remember, that has an inverse relationship with ferritin. If the ferritin's low, the TIBC is going to be high, because there's not enough iron in the storage to go around. And so we have all these open arms waiting to bind with that iron, but there's not enough iron to go around for everybody. So those 2 have an inverse relationship. And then, like I talked about, the hemoglobin electrophoresis or hemoglobinopathy panel, that's going to help to sort out between thalassemias or sickle cell versus if we're just dealing with iron deficiency. So this is something that if you get a low MCV, and whether or not your patient is symptomatic or not, you might consider running some of these labs. Again, this is all to determine if it's a microcytic anemia, okay? So we've talked about elevated red blood cells. We've talked about some of the easy things that we know can cause an increase in elevated red blood cells. Things like smoking. We've talked about sleep apnea. We talked about high altitudes, blood pressure medication. That was one I didn't put here for you. But there is one thing that can be kind of deadly to the patient, and it's a must not miss diagnosis. So if you see that those red blood cells are elevated, we want to make sure that they do not have a condition called polycythemia vera, and that basically the thickened blood leads to a state where they can really develop a lot of blood clots. Oftentimes, this is going to be treated with like aspirin or some other antiplatelet or anticoagulation therapy. This is going to be something that the patient is going to require lifelong. It's going to be treated by hematology or co-managed with hematology because it's dangerous for the patient otherwise. And these patients are going to have frequent monitoring if they have this. And one of the things that we can order if we see elevated red blood cells, if we see elevated hemoglobin and hematocrit, is that JAK2, which will help to determine if they have polycythemia vera or not. But again, just the main thing for boards that you need to know is erythrocytosis is the fancy name for elevated white blood cells. And if they have that, we need to rule out polycythemia vera. Okay, so if you know that, you're going to be okay for boards. All right, so that's the basics of your labs that you're going to be doing in primary care for microcytic anemias. Again, if this gets to be confusing, I remember it used to feel very overwhelming. I've had lots of talks with, some of the collaborators I've had or other nurse practitioners about this before I really got good at this, and just like practice makes perfect. So the more CBCs you look at, the more of these ancillary labs you're going to know what to order it, and the more proficient you're going to become. Okay, so again, this is just kind of an overview here. All right, so let's go ahead and just pause for a minute here before we get into any of our questions or our case studies or anything, and talk about these exciting things that we have coming up. We have a 3-day live review coming up in November, and the way to get in on that is to register for SurePass. And SurePass is going to be great because it's going to combine, it's going to give you the Q Bank, which always has a free 7-day trial. Sam's already linked it for you in the chats. So if you haven't taken advantage of that, go ahead and do that now. There's over 1,600 questions. We've been scrubbing the questions down, trying to add more pictures and things for y'all. And that's really a great resource for you. It has a readiness predictor within that Q Bank, so you can kind of take those questions and see where you're at. They all have a rationale with them. And then the SurePass has that. Plus, they also have the on-demand package. That's 16 plus hours of content, really broken down into bite-sized pieces. When you come to these free live webinars or even the 3-day live review, we're giving you a bird's eye view. We're giving you the quick, down and dirty details. But it's really important before you sit for boards, and especially before you go to practice, to really understand the why behind what we do, the evidence-based practice and the guidelines behind why we're doing what we're doing. And this on-demand video is going to help you to do that because they really break it down for you, again, in bite-sized chunks. If you're in nurse practitioner school, even if you're not even in your last semester or two, you can still go and get this on-demand package, and you can look at it, and you can be doing it right along with your classes as you go along, so that when you have 4 hours of lecture and you're feeling brain dead, it might be broken down into a 15-minute video for you, the quick, down and dirty version. So this is something that you can be using either while you're in school and while you're prepping for boards. And then again, this has everything all included in addition to the 3-day live review. And if you get the SurePass, there is a pass guarantee. So again, lots of resources on here, lots of different packages depending on the price point that you're looking at, your budget. We have questions. We have an email for questions for you if you're not sure which one would be best for you. And then also we want to connect with all of you. Archer, I love how everybody is not just a number, but you're a person and you're a student, and we want to see success. We'd love to hear your success stories. So even if you don't buy anything, we want you to do your free trial of your Q Bank. and continue coming to our free webinars, looking on our social media, how I have listed here on the bottom of the screen for you, because that's really going to help you put up questions of the day. We have these little case studies on there. And again, there's nothing for you to buy. That's completely free, just like you're doing here today. So again, we really are invested in your success. So let's go ahead and practice. So I know that was a lot of information on, iron deficiency, anemia, the microcytic anemias today. And this is something that is just going to pretty much take practice. Now, for those of you who want to know what macrocytic anemias are, remember when the MCV is over 100, we're going to be checking that vitamin B12. We're going to be checking, do they use like alcohol? We're going to be checking like a folic acid level. And if they're just anemic and they don't really have anything else, like their H&H is just low, but their MCV is normal, we can call that a normocytic anemia. A lot of times we see that like in chronic disease, especially like chronic kidney disease, things like that. So again, today I really wanted to focus on this iron deficiency anemia. But in the 3-day lab review, we break down all the types of anemia and really go through it, okay? So the nurse practitioner is reviewing iron studies for a geriatric patient with chronic kidney disease and a history of anemia. Which of these components correlate to the iron storage? So again, this one right here, very common to see chronic kidney disease patients anemic. Oftentimes, again, like I said, it's a normocytic anemia. And absolutely, Marilyn is right on it. Great job. We've already talked about that. Ferritin is your iron storage measurement. Absolutely. And of course, we can order with it a TIBC, something like that. And I love this little thing that I did not write this one, but an analogy to consider for iron components is like you're paying your bills. If iron is like your checking account and you don't have enough money in it, you will use your savings account to pay the rest of your bills. And ferritin is like your savings account. So that is really the last stop there before you are completely depleted of all of your iron. So again, great job. You guys are already on it today. All right. The nurse practitioner knows that sickle cell anemia is prevalent in which of the following ethnic groups? So which one do you guys know is going to be really important to screen for your sickle cells? And if we start having some of these anemias. Guys, remember? We didn't talk about this necessarily, but you probably have studied this. Marilyn's already guessing. Great job. So sickle cell anemia often really affects these population of African ancestry. This is a disorder that causes chronic hemolytic anemia. Children with sickle cell don't form a normal molecules, and they synthesize this, and it can cause like pain crisis, organ ischemia, other systemic complications. And can you guys tell me, that's not on here, but can you guys tell me what is the most common issue with sickle cell patients? Like what do they either have complications from or even end up passing from? Do you guys remember? You guys are really on a roll today. So do y'all remember? Y'all can put it in the chats. I'll sit here and wait for just a minute. Do y'all remember what we really need to be watching for? And just as a little hint, like we're going to really encourage things like vaccination, things like that, because we want to prevent this. Do y'all remember? Absolutely. It's infections, right? Very good. All right, so which of the following can be described as an autoimmune disorder that creates antibodies against intrinsic factor leading to vitamin B12 deficiency? So remember, we talked about vitamin B12 deficiency is that macrocytic anemia. Today, we really focused on microcytic anemias, but do you guys remember on this one? Just as a little review, I tried to put different questions in here for y'all just to practice. Absolutely. Yes, Marilyn's on a roll today. Choice B, pernicious anemia is that autoimmune disorder where the body produces antibodies against intrinsic factor, preventing the absorption of vitamin B12 in the small intestine and leads to that macrocytic anemia, right? So you're going to probably see your MCV is well up over 100 and your B12 might be low. All right, so this is what y'all came for, right? Was our case study resolution. So we on TikTok or Facebook or wherever you might have seen it for the questions of the day, met Annie this past week. And Annie is a 16-year-old girl, and she's been complaining of dizziness and some heavy menstrual cycles lately. And she's brought into your clinic by her mom today. And let's go ahead and read a little bit of more background, okay? So she's 16 years old. She's coming in with her mom, accompanied by dizziness. Mom states she looks pale and felt dizzy when she arrived home from soccer practice on Saturday after being on her menstrual cycle over the last week. And the nurse practitioner will begin workup. Okay. And you guys get to be the nurse practitioners today. So I will pause at the end of all these slides and let y'all put in the chats. And remember, this has a lot of things to go with it. So we're going to really take our time as we work through this. Okay. So, health history for Annie. All vaccines are up to date. She had her tonsils taken out at age 6, but otherwise she is healthy. There's no pertinent family history that pertains to anemia. She's not yet sexually active. Her vital signs are within normal limits today, and she has had a normal physical exam. Her urine pregnancy dip has been negative, and her urinalysis dip was also negative for nitrites. Okay. So here's some information for you, pertinent information. Menses began at age 12. She's had some menorrhagia and dysmenorrhea for 2 years, so starting around age 14. And she denies any palpitations, shortness of breath, or syncopal events. So y'all take it from here. What labs do you all want to order? What diagnostics will you run? So y'all can work this together. And if you want to unmute and talk about it, you can do that. Again, this is relaxed and informal. This is your time. So what do you all want to do for Annie's workup to get started? So I will pause my mouth and let y'all take over. All right, I'll give you just a minute to put in the chats what you'd like to do. Okay, so I see a CBC coming through. Very good. What else do y'all want to put in the chats? What else would you like to run? Anything else? Anything else that can cause dizziness that you guys think about? So I know our leading thought is maybe an anemia, but is there anything else that we need to rule out? About like anything with thyroid stuff? Anything? Think about 16-year-old girl. What would you want to maybe else think about? Anything else? Might be causing her dizziness? Okay, thyroid panels. All right, let's take a look here. All right, so we went ahead, we ordered a thyroid panel. We, of course, ordered that CBC that we wrote. We saw on here that the hemoglobin hematocrit was a little bit low. So we went ahead and had the lab to iron that ferritin and TIBC on. We had them to add that in. And then we also went ahead, since she's been having heavy and painful periods for the last 2 years, We also went ahead and added in an abdominal and a pelvic ultrasound, right? Because we were trying to get to the bottom of this. So why is she having heavy and painful periods? Does she have some sort of issue going on, like, PCOS or endometriosis? Or, is she just trying to get regular? It's been going on for 2 years. She's anemic at this point. We need to figure out what's going on with her. Okay. So, what would you all like to do? Take it from here. What medications will you prescribe? What education will you provide? And when should she return? So, what do y'all think? So, think about what you would prescribe for Annie. Think about what you want to talk to her and her mom about. And then when do you think she should follow up? What do you think we should do for this patient? And you guys can put it in the chat. So we'll talk about it as you put it in there. So we have a normal abdominal and pelvic ultrasound coming back. We have a low ferritin and high TIVC. We have normal thyroid. And of course, we can see that her MCV is low. Her red cells are low. White cells are normal. And H&H is a little bit low. Platelets are a little on the low side, but they're normal. So what do you guys want to do? This is what you get back. So where do you want to start? What are you thinking? When do you think we should recheck her labs? And is there anything that we need to educate her on? Any additional questions you'd like to ask? And absolutely, Sam is right. This is a safe place to learn. So this is the time to be figuring out what you'd like to tell this patient and what you'd like to prescribe. All right, so let's just start with some yes and no's. Do you all think that she needs iron? Yes or no? Put it in the chats. Do you think she needs iron? Yes, very good. Absolutely. She does need some iron. What iron dosing do you want to give her? What do y'all remember the standard dose of iron? It's going to be daily. So it's going to be 325 milligrams daily. And we're supposed to recheck it 2 to 6 months after starting the medication. Okay, so there's a little hint there. All right. Do you guys think that dysmenorrhea is a painful condition? We've already put painful periods on there, and we've put menorrhagia, heavy bleeding. Do you think that this can cause this patient some pain? She was on her menstrual cycle the entire week prior. Do you think that even though it lasted 7 days or whatever, do you think that that was a rough cycle for this patient? She's anemic from it, right? So is there anything that you all think? We always want to try to group our medicines and kill two birds with one stone. So can y'all think of anything that is going to help slow the bleeding and help with pain that would be good for a 16-year-old kid to take? So there's a medication I'm thinking of. It works to slow down prostaglandins. It means less uterine shedding, fewer cramps, and less bleeding. Do y'all know that one? It's pretty common. Something that would be safe for a 16-year-old. So what you thinking? So we're going to encourage iron. We already established that if you're just joining us. And we're also going to say that this patient can take some ibuprofen, okay? And ibuprofen, it not only helps with pain, but it also works to slow down prostaglandin production. It means less uterine shedding, fewer cramps, and less bleeding. So again, we're going to kind of kill two birds with one stone with that, okay? What do you all know as a side effect of iron? Is there anything that this patient may complain of when she's starting iron? So let's talk about the educational aspect of this. What do you think the iron is going to do to a 16-year-old girl? What do you think she may notice? Is it normal or abnormal? That's right. Dark stools, stomach upset. I would even add constipation to that. Great job. So we're going to let her know that this can turn her stools darker, right? It can cause some belly discomfort and constipation. So is anything that we can remind her to do or take? Do you think 16-year-olds eat a lot of fiber and drink a lot of water? Do y'all think that's the case usually? So what are we going to educate her on? Drinking plenty of water, adding some extra fiber in, right? Using, a stool softener or a little Miralax, something like that to help her if she gets constipated. And she needs to call back if she doesn't have a bowel movement within 3 days if she has constipation, correct? What about her iron absorption? Do you all remember the what helps iron to absorb? Do y'all remember that? A lot of times we give it with orange juice in the hospital. Here's an old med-surg nurse here. If the patient wasn't diabetic, we would give it with orange juice. Why is that? Why do we give iron with orange juice? Y'all remember what helps absorption of iron in some studies? Vitamin C, right? Absolutely. Okay. And then if she's soaking more than one pad in an hour for 2 hours, she needs to go to the emergency room, right? So if she has another horrible cycle and we need to have her to monitor her bleeding when she is on her cycles and making sure that she's not soaking a pad or a tampon every hour for 2 hours or more, she needs to go to the emergency room. She also needs to call back if she starts to exhibit some of those signs of worsening iron deficiency anemia, right? She's already dizzy. She's already probably feeling weak. She's already a little pale. She might even have a little bit of feeling cold or brittle nails. But if you start noticing, if mom starts noticing that she is having like shortness of breath or syncopal episodes, things like that, we need to also send her to the emergency room and see her back quickly, correct? And then after we give her the iron and the ibuprofen, we're going to have her return to the clinic in about 2 to 3 months. And if she's not better, where are we going to consider sending her to at that point if she's not responsive to the iron at that recheck? Do y'all remember? What referral would we need to make? So it's really important as a nurse practitioner to know where we end and specialty begins when we're in family practice. So do you guys remember where we would send this patient to? We probably need to chart this on our plan of care. When I'm charting, I like to, go ahead and be thinking about what the next step I might do if the patient's not responsive to my plan so that I don't have to think as hard the next time. So what might I put on my note today? Absolutely. So consider follow-up with GYN, consider follow-up with hematology for iron infusions, or if she has severe constipation, consider iron infusions. Absolutely. Very good. Okay. So let's go ahead and take a look at the 2 to 3 month visit mark. Okay. So her symptoms are resolving. Her and mom come back to visit you about 2 to 3 months later. This is her new updated complete blood count. This is her new updated ferritin and TIBC, and her symptoms are resolving. So what y'all think? Anything else that we need to do for this patient? Any other points that we need to talk about for her? Anything else you want to say? Don't be shy. Okay, so we've talked about how if she wasn't getting better at this point, we would consider making a referral, right? If she starts having this again, she needs to let us know, right? And then we may be able to discontinue the iron coming up. Probably would keep her on it for a little while and just continue to monitor for, maybe another month or two. And then we might be able to discontinue the iron, but she's going to need to eat iron-rich foods and continue the ibuprofen as needed, right? All right. Great job today, guys. Again, I'm going to stop here. And I hope that that was helpful for you to walk through this anemia, specifically microcytic and iron deficiency anemias today. I hope that you will join us for our upcoming 3-day live review that we're going to be having next month. You can do that by registering for SurePass. We'll be talking about all the anemias there. The macrocytic anemias, microcytic anemias. So we'll be going back through that. If you have not done so, I want you to sign up for the Q Bank, because the Q Bank actually has several of these questions that we've talked about today that you can go through and look over the rationales. So that's something I would consider every time. You can use that. And then, of course, on demand. Sorry, I feel like I'm going to sneeze. Of course, on demand. So it was great to see all of y'all today. Happy Monday. I'll plan to stay on here for another minute or two, and Sam will stick around in case y'all have any questions. Again, we'd love to connect with you all on our social media and our email if you have specific questions that we can help you with. We would love for you to join our community here. It's a great community, and we'll plan to see you soon. I think we have some more upcoming webinars this week, so be sure to check out our social media page for that exact schedule and speakers on there for you. And otherwise, I'll see you all next week, same time, same place. And again, feel free to reach out.